uh, good, really early morning, like 2 or 3, depending on where you are in the world. Today, we're going to be talking about blood pressure. It's also very much related, like prediabetes. It's very much related to heart attack and stroke and the things that kill us and disable us. We'll talk a little bit about medications and some of the standard things that people talk about. Well, as with everything else in the chronic disease world, you can't out medicate or out prescribe lifestyle. We'll talk about that too. But I'm going to talk about an interesting little device. I've mentioned it before. There was a group that it's called Respirate. It's a device assisted breathing. They saw my channel and gave me a call and wanted me to look at their product. I thought, okay, you know what? I know that there's some interesting stuff about slowing your breathing and blood pressure. And I thought, maybe not, probably not, but I'll take a look. Well, I was surprised as I got into looking at the background on this. This device has full evaluations by the American Heart Association and even the FDA. And believe it or not, both of them agreed with them and recommended them. So, or at least FDA approved them. Both of them approved them. That got my attention because those are both very conservative groups. So what the core part of what we're going to talk about today is those science reviews on different things: blood pressure management, using just slowing your breathing down, using biofeedback, obviously using supplements and blood pressure meds, but also using these things too. And I think you'll find some interesting stuff there. I'll tell you, I'm still using my device. It made a huge impact on my blood pressure. One of the things you think is that, well, it's not going to be permanent. I got about between 10 and 20 points decrease in my systolic pressure. And so far, it's remained a pretty stable decrease. So it's been a big deal for me. Full disclosure, I do have one of these on our website. I do get some kind of commission on it, but commissions are not driving any of my stuff that you see on my channel. If I had to go by commissions, I'd be in a very different place in this world. We're actually the biggest income that we get these days is from me actually seeing patients. That supports the channel. We're actually having some meetings about starting some clinics and even developing a health plan. You too can join that health plan if we get it up and rolling, but you'd have to move to LA, and not the LA you're thinking about, Lower Alabama. Different issues for different times. We'll talk about that more as it becomes a real issue. One of the things we'll always do is provide us some clarity and help you fill your gaps in care. What are the gaps in care that I'm talking about? Most docs really don't know as much as they need to know about prevention, and specifically about some key areas of prevention: how to evaluate plaque in your arteries, how to know and evaluate how much insulin resistance, prediabetes, or diabetes you have, how to deal with those things. Supplements, again, these are areas that are important, especially the first two. And they're areas where the science is really clear. Your typical internist, your typical family practitioner, even your typical cardiologist, although they've had some training in prevention, they have gaps in those areas, especially in the major cause of heart attack, stroke, disability, and death, and that is prediabetes and diabetes. So there's not enough prevention docs going around. I can't treat everybody in the country. There's not enough prevention docs that could treat everybody in the country. So the reality is, it's sort of a buyer beware, caveat emptor, that old Latin thing. And that's scary, but it still is what it is. If you look back at blood pressure, 50 years ago, blood pressure was where insulin resistance and prediabetes is now. What I mean by that is this. They were beginning to discover the importance of blood pressure, but most people were just not measuring it. We didn't know how to manage it, let alone measure it, how often to measure, and things like that. Blood pressure management has always been simpler than glucose metabolism measurement. But again, the importance was not understood until the past 20 to 30 years. Now, we have made huge progress, not me personally, but our whole medical complex, the medical profession has made huge progress on management of high blood pressure just over the past 2 decades. But again, it took 5 decades to get us there. I expect it's going to take us several more decades to have a similar impact on prediabetes. Until then, and so most of us who have the problems don't have that kind of time, don't want to wait that kind of time. So unfortunately, you need to learn what you need to know to evaluate your prediabetes, evaluate your plaque, and figure out what to do about it. That's what our curriculum is all about, helping you fill in the gaps that most doctors have, primary care docs have. There are several ways to do that. The first one is webinars. The webinars, in terms of cost, a couple of $100, and it takes you a couple of hours. That's too much. We've developed these in terms of courses, do-it-yourself kind of courses. These range from $19 on sale up to about $50 is the most we've charged for it. And again, in a couple of hours, you can learn more about the major causes of death and disability and your most likely risk for death and disability. You can learn more than most doctors will know. People have continued to ask, well, how can I get a little bit more care, but I've got a budget issue. That's why we developed the monthly subscription plans. Again, one of the other option is just to trust the standard practice that you see out there. Get a stress test. If that looks good, then you're fine. Maybe adjust your medications. There's too many people that have died from that kind of care. And Tim Russert is a poster boy for that. His death was 10 years ago. He had passed his stress test with flying colors, had a heart attack 3 months later, and died. His doc was a very, very good doc, knew a lot about the standard provision of care, and even knew a little bit more about cardiovascular inflammation than most doctors knew. But still, too many people are dying from heart attack and stroke and never knew that they had cardiovascular inflammation, insulin resistance, even full-blown diabetes driving this problem. He was one of them. So there's other information. If you have other information on how to or other questions about how to access our information and care, you can find that on our website. So today we're going to talk about blood pressure and breathing, device managed or device assisted breathing. Just a couple of things about blood pressure first. You know, these are a couple of slides from the company that makes this thing. I wouldn't say that it's deadlier than ever. I would say that it's deadly. You know, there's 80 million in the U.S. Does that begin to give you some? Does that ring some bells? The CDC would also say there's about 80 million people with prediabetes, 90% of whom are undiagnosed and unaware. And I'm going to go over this continued relationship between high blood pressure and prediabetes. We'll cover some actual details in that space and mechanism in a few minutes. 9 out of 10 middle-aged adults are going to get high blood pressure. It leads to stroke, heart attack, kidney failure, and more. It accounts for about 14% of deaths, and half the patients with it are not controlled, despite medication and lifestyle changes. It doubles the COVID-19 morbidity and mortality, and I think that was the point that these guys were making in the title about it being deadlier than ever. Now, I mentioned the link between prediabetes and blood pressure. There's a major linkage there. If you start looking at charts and graphs of chronic diseases, what you'll see is we all start falling apart in our 40s, 50s, and 60s. Well, why is that? We have specialists to look at each body part. We have neurologists to look at dementia and strokes. We have ophthalmologists, eye doctors to look at the damage associated with eyes, cardiologists to look at the damage associated with hearts, nephrologists to look at the damage associated with kidneys. All of these are actually caused by the same things: high blood pressure, prediabetes, diabetes. So as you begin to realize that, you begin to look at, there's a cellular problem going on that's tearing up our arteries. And if our arteries if it tears them up in the kidneys first, then we start getting kidney disease. If most likely two big tissues that you get this artery damage would be in the heart and the brain. That's why you get heart attacks and strokes. There's a thing that you may have heard of, AGE. Now, I'm not talking about aging, getting older, although that's very much related to this. I'm talking about advanced glycation end products. Those are proteins that glucose has bound to. And if you look at the kidney has a thing called its filters. They're glomeruli, but you don't need to remember that name. The kidney has filters, and the filters have what's called like a thermostat in your house. They have a sensor which tells, are we getting enough filtration? Well, those filtration thermostats tend to get clogged up by advanced glycation end products. Now let's go back and connect the dot. What's the most common advanced glycation end product, or the most well-known? Hemoglobin A1C. So when you begin to realize that hemoglobin A1C and the other advanced glycation end products can start clogging up the filters in our kidneys, start causing those thermostats to say, hey, we're not getting enough filtration. You need to increase the blood pressure. You need to increase the volume. You need to squeeze those arterial walls. Then you begin to start understanding the relationship between prediabetes, blood pressure, and the other chronic diseases. Now, most people think, well, it's the arteries themselves, those big arteries. It's hypertension, right? High blood pressure. Hyper meaning too much, tension meaning too much of a squeeze. So they think of that in terms of the arteries. That's almost correct, but not completely. So if you look at this diagram, there are three things that can cause that kind of resistance and push. Obviously, how hard the heart pushes on the blood. The second one is the large arteries, what most people think about. The large arteries can cause some problems, but here's where the real issue is. They're called arterioles, the smaller arteries. And if you look at the actual surface amount, the biggest amount of surface by far is these small arteries touching the blood. And that's where we get into hypertension. In fact, the number's so big, I can't remember it. I can't remember if it's 6,000 miles of arterioles in our body or 60,000. I mean, it's mind-boggling. Every tissue that gets blood because of these large arteries feeding those small arteries. So that's where we get concerned about this squeezing causing high blood pressure. So let's talk for a minute about about blood pressure, and the first thing that most docs go to. The first thing they go to is medications. Now, there are a couple of different. I'm going to go over four common types of blood pressure medications. We'll talk about a little bit of pros and cons. But this is not so much a video about blood pressure medications. We can do other videos on that later on. This is about, again, breathing assisted devices. But just a couple of comments about the medications before we get into the impact of breathing and the mechanism of breathing assisted devices on blood pressure. ACE inhibitors, that's one of the first things you'll hear from me. That's the first medication class that I'll go to. There's a couple of reasons for it. Number one, it lowers the resistance of these arterioles, but it also improves the cardiovascular inflammation. That is a really big deal. For those of you unfamiliar with this channel, just Google my name and then CV inflammation or cardiovascular inflammation. We've got dozens of videos on cardiovascular inflammation and its causes associated with heart attack and stroke. The second most common medications that you'll see today are calcium channel blockers. They do the same, they have a very similar mechanism. They decrease the power of these little yellow arrows, the squeeze on those arterial walls. They also have some other impacts on how hard the heart is pushing. But those are not significant right now, and we're not going to cover those in today's discussion. The two of them are commonly used blood pressure medication classes in the past were diuretics and beta blockers. Diuretics, fluid pills. And as I mentioned before, there are two ways to increase your blood pressure. Squeeze those arterioles a little bit harder, or decrease the volume, the fluid in the blood. And we noticed that with diuretics, fluid pills long ago. So those used to be the go-to medications. But what we have found from the science, from looking at the evidence over and over, is that diuretics really, they used to be the first line medication. They really shouldn't be in the vast majority of cases. The vast majority of cases should be ACE inhibitors or calcium channel blockers for starters. Beta blockers are still the first an important category, but they're still way overused. Most beta blockers can actually cause some prediabetes or make it worse. Beta blockers are important, especially in terms of how hard the heart pushes. Now, here's the thing. They are very important for people that have some level of heart failure. Now, I'm not going to get into heart failure today. One of the things we're discovering more recently about heart failure is that it's very similar to the case with atrial fibrillation, very similar to the case with prediabetes. In other words, there are tons of people, maybe most people with some heart failure don't know it. It's what we call New York stage 1, totally asymptomatic heart failure. Now, heart failure is the one time when you do want to go ahead and have beta blockers, that and when you've had a couple of other heart-related items. For the vast majority of us, though, it's a mistake to start with beta blockers. So take a hard look at the medications that you're on. If you're on diuretics, beta blockers, you may just want to check that out and make sure that those are the right choices for you at this point in time. Now, we'll get away from medications for a while and talk a little bit about, wait a minute, doc, what about lifestyle? Lifestyle is key. And it's so true. You can't out-medicate a lifestyle problem. You can't prescribe, out-supplement a lifestyle problem. And in terms of lifestyle problems, you really can't outrun a diet. Diet is the number 1 and number 2, maybe number 3 component of chronic disease management. It's the same with high blood pressure, just like it is with prediabetes. With high blood pressure, you really want to make sure you keep that weight down, keep a minimal body fat percentage. Exercise is very important. Again, not as important as diet, but it's very, very important. Now, I'm going to go into another area real quick in terms of talking about breathing and lifestyle-related issues. Many people will say, Doc, yeah, okay, we agree with you. Like you said, there's always been some evidence that breathing has an impact on blood pressure. There are actually a couple of significant, fairly well-known programs involving meditation, involving just specific breathing-related management of blood pressure. One of them is Dr. Herbert Benson, a director at Harvard, associated Benson Henry Institute for Mind and Body Medicine. There's a couple of other mind and body medicine programs that have great recommendations, great science behind them, and great evidence recommendations. But here's the thing. Take a look at the science, the literature. We'll cover that in just a minute. Now, what are we talking about? Let's go back and answer the question. You've said device-associated blood pressure a couple of times. Respirate is I think the leading product in that area. Some people have said, "Hey doc, I know," and there's some great great apps on your iPhone. I've looked at some apps. I haven't found an app. I've used several apps in this space, and I just haven't really found one that had this kind of impact. Let's look a little bit deeper. What is it about breathing that actually helps manage blood pressure? It has to do with what we call sympathetic tone. In other words, that fight or flight principle that creates the tension in those arterioles, those small arteries. Now, there are things that happen with breathing. One is there are pulmonary or lung stretch receptors. There are also cardiac stretch receptors. So when you breathe in and breathe out, these stretch receptors are impacted. What happens next is that goes to your brain, and your brain stem signals these processors and decreases the pressure shown by these yellow arteries. I mean, yellow arrows. Again, it focuses on the sympathetic nervous system. There are two major components to breathing that have this impact. One is the rate of breathing, and that's what you'll see time and time again with a lot of the meditation-related things. Your typical rate of breathing is about 20 per minute. You want to slow that down to 10 or less. That sounds like a lot. When you first start practicing that, that's going to feel weird. You're going to feel a little bit of air hunger as you do that. As you get used to it, you'll get used to it. And you'll probably see some impact on your blood pressure if you're doing that. But there's another component of breathing that this device is really good with, that you tend to not see in a lot of the others, and that is what we call a prolonged expiratory phase. What you want to do is decrease. You want to decrease the amount of time that you're breathing in and increase the amount of time you're breathing out. So what you begin to see, and some of the meditation related instructions do actually get into some detail on that and do actually talk about you exhaling with your mouth. There are things in our wiring, our brain, that respond to that. Now, for those of you like myself who've been very skeptical about this, you're not alone. This was Russell Zunzman, associate professor at Harvard. Most of the studies to support respirate are short, don't have enough numbers for participants, aren't carefully controlled, etc. That's his quote. I've had concerns again for the many years that the first 30 years that I was practicing prevention. But it certainly wasn't. And so you can see some of the skepticism that I had when this group called me and asked me to test their device. Some researchers even said, look, the American Health Association needs to rethink it, maybe pump the brakes on this device-guided breathing. And we're going to get into the details. This is what they're talking about. Again, it's that device which helps you measure the number of breaths you're taking per minute. It coaches you on a breath-by-breath perspective. And it also coaches you on the prolonged expiratory phase. Again, a couple of very conservative groups, the American Heart Association and the FDA, cleared it for use and provided a recommendation. Why did they do that? Well, again, as I said before, I looked at this originally, didn't look deeply into device-related stuff, mostly looked at meditation, looked at biofeedback. Where I saw real impacts were losing weight and medications. And then these guys called me and I gave it a try. And these are the numbers that I started getting. This was at a time when my blood pressure I've always struggled with it. 120 systolic was a really, really good day. Most of the time I was at 130, low 130s. And again, that was one of the things that always motivated me to keep my weight down. I'd gain 5-10 pounds. I'd gain another 5 to 10 points on my blood pressure. Now, I had a very significant impact. I ended up using, as you can tell by my voice patterns and the way I present content, I tend to be very hyper in terms of some details, especially around these areas. The recommendation for Respirate is to use it for 5 to 10 minutes, 4 times a week. I was much more of a overachiever in that space. I got my device. I was using it at least twice a day when I woke up, when I went to bed. I also, for the first couple of weeks, used it a couple more times per day. So I was really getting used to the changes in the way I would breathe. And I found myself very quickly when I'm standing in the kitchen talking with Janice, my wife, changing the way I breathe. So again, I started getting some significant changes in my blood pressure. And guess what? Those have not gone away. So you can tell me maybe uninspired, maybe not great evidence. It's working for me. Now, let's go back and talk about the evidence itself and how the American Heart Association, for example, came up with theirs. So I asked these guys to give me their what they knew about the information, and this is the way it's set up. The American Heart Association looked at things like, as I said, meditation, yoga, biofeedback, relaxation therapy, exercise-based things like aerobic and endurance exercise, resistance and isometrics, and non-invasive devices such as acupuncture and breathing, device-guided breathing. Here's the way that the American Heart Association and any other practice recommendation standards committee is going to look at evidence. You're going to have class 1, which is a big benefit compared to the risk. Class 2, still an undeniable benefit compared to risk. Class 2B, which is where a lot of supplements would end up falling, where you can see, yeah, there's a little bit more benefit, but in a lot of studies, not so clear. And then class 3 is just no significant obvious benefit over risk. There's the other component of looking at these. That's the benefit risk ratio at the top. Along the side, you have the classification of the data itself, with the most important, the most compelling evidence being multiple populations evaluated with randomized, blinded, double-blinded clinical trials, RCTs, randomized clinical trials. That's the best information. The second best information is what we call level B, limited populations evaluated and some randomized clinical trials. And then level C is very limited populations, expert opinions, case studies, and things like that. So here you go. Here's where, again, I'm giving you the AHA, the American Heart Association evaluation, not mine. And their group, when they looked through all the science, said, yes, class 1, huge benefit compared to risk. Aerobic exercise, level A, multiple populations, randomized clinical trials. So from an aerobic exercise perspective, you got to do that. There's no question whatsoever. Then you get to level B, limited population evaluations, and the class 2, significant, undeniable improvement. That's where device-guided breathing comes in. Now, look at all the other things that other people talk about and say, oh, this will really work, and it'll work as good as some silly device-guided thing. No, not at all. Resistance training, not so much for blood pressure. I think it's great for prediabetes, but it's okay, and it's clearly good. There's no question about it for blood pressure. But then you start getting into transcendental meditation, clearly biofeedback, isometric exercises. I still recommend these. There's no question. In anything in the green, yellow, or orange, I would recommend. Class 3, just not seeing it. Acupuncture falls there. Relaxation therapies fall there. Other types of meditation and even yoga. Now I'm not saying don't do yoga. I know I'm going to get a lot of haters. If you're afraid of haters, don't go on YouTube. But I'm just giving you the findings of the American Heart Association statement. And from what I've seen, looking at the science myself, I would agree with the American Heart Association group. Clearly aerobic exercise, resistance exercise, and I would recommend device-guided breathing. Yes, I would recommend TM, biofeedback, and isometrics, but again, not as much as these other items that we just talked about. So there you go. That's the device-guided breathing. As I said before, yes, I think I've gotten 2 commissions on those. So I'm not interested in commissions. I'm interested in providing good information. And if you're interested in that, you can go to their website or mine. I think their website is respirate.com. I know I found it fairly easily when I started investigating this this type of blood pressure management. So this ends our presentation for the day. I'm going to back up and let Gilbert give us the water ball. With a lot of comments today. Daydreamer. Normal BP is 110/72. Good for you. Occasionally when I get stressed or GERD, gastroesophageal reflux disease, it can go to one. That's a very bad medical case of heartburn. It can go to 160/95. That is not good for a while. Should I be concerned? Yeah, I think you want to start documenting how much of your day you're in that kind of blood pressure range. And I would start looking at all the things we talked about, even including it, I hate to say it, including the potential for medications, especially when you're in those episodes. 160/95, even if it's a few times a week or a few times a month, that's not something I would want you to be suffering on a regular basis. I take blood pressure medicines and started WFPB diet, whole food, plant-based, 6 weeks ago. Well, good. I'm glad you're managing your diet, and thank you for sharing. Brian Edwards. Hi, Dr. Brewer. My doctor manages my blood pressure with my arm hanging down and my hand touching my thigh near the knee. Is this acceptable in terms of getting an accurate measure? You know, there's a whole bunch of argument and debate about, should you be lying down? Should you be seated? Should you make sure you watch your, get a cuff that's the appropriate thickness? If you're seated, that's a big deal. That helps. I don't think I'd start anybody on blood pressure meds without multiple seated numbers. Hanging down, it's probably a little bit better to have it balanced on, laying flat on a table than hanging down, but I doubt you're going to get that much of a problem. What you can do, I have it in the other room. You can get these Omrons. They're good now. The automated blood pressure device. And if you don't have one, if you're on medications and you don't have an Omron, you really should get one. Thanks for the comment. Bart Robinson, good to talk to you today. Good morning. Looking forward to the topic. Fort Worth West Side. Hi, Dr. Brewer. Is it unusual to have a difference of as much as 10 to 15? Oh, no question. Systolic between the left and the right upper. Oh, I'm sorry. I should have finished. I should have stopped, listened, finished your question before I responded. There are some conditions where you get that kind of difference. You need to make sure that you've pointed that out with your doc and that your doctor has consciously evaluated and screened you for those conditions. If he or she has not done that yet, they need to do that. Great question, Fort Worth. I appreciate it. Daydreamer. Hello, Dr. Brewer. Nice to see your live broadcast. Thank you for mentioning that. I apologize for having to switch our to this week's time from Wednesday at 11 Eastern to Thursday at 11 Eastern. We had a meeting in Nashville yesterday with the groups, like I said, for the Medicare Advantage programs. We're planning right now to have not only clinics, but again, a full-blown health plan focused on providing this kind of prevention. Now you can, if you're saying, I'd be interested in taking a look at that, we'd be happy to take care of you too. However, you'd have to move to LA. No, not that LA, Lower Alabama. So it will be limited to folks that that live there. Simra Basivan. Good morning from the Netherlands. Thank you so much for making me aware. It's great to hear where you're from. Thank you for your wonderful lessons, and thank you for your interest. Abdurrahman Abbasan. I hope I got that right, or at least didn't do it too badly. How can an orthopedic surgeon implement prevention strategies in his practice? That's a great question. I guess you're Dr. Albasam. Some very basic things like blood pressure screening. It's interesting. I talked earlier about how we are here in 2021 where we were, in 2021, we're with prediabetes where we used to be back in the 70s, 80s, 90s with blood pressure medicine. So Dr. Albasam, one of the things, for example, you probably do in your practice, because most specialists do, orthopedists or whomever, you usually get a blood pressure when a patient comes in. It's simple, easy, and it's important. A very simple thing that we need to, well, it may be not so simple, but a very important thing, more important, in fact, would be to make sure that your patient has at a minimum A1C, but really that's not enough of the picture. I wish if it were my world and I could change whatever I could change, I would have every doctor make sure that every one of their patients has had an insulin response survey at least every year. Insulin survey, basically it's an old-fashioned OGTT, oral glucose tolerance test. Most doctors, even orthopedists who don't really spend that much time in this area, have had exposure, and most of them know what an OGTT is, oral glucose tolerance test. It's where you fast the patient, you get a fasting glucose, and then you give them a challenge to see how their body manages glucose. So you challenge them with 75 or 100 grams of glucose, that sweet drink. Then you measure glucose levels at 1 hour and 2 hours. The insulin survey is basically the same thing, but it's also measuring insulin. And you get a huge story. That's where you begin to discover these more than 100 million people in the United States that have prediabetes and don't know it, and are on their way to this blood pressure problem, and on their way to heart attack, on their way to stroke. So that's one way to do it. If you look at other ways to do it, we're going to be, one of our plans, for example, in the Alabama program is to start working with specialists to say, look, if many people don't have specialists, if you look at the plan groups like Anthem, Cigna, some of them are starting to ding the specialists, like the cardiologists, and saying, look, you didn't get a hemoglobin A1C, or this patient has not had a hemoglobin A1C in over a year. They don't see another family practitioner. They don't see another internist. So we're appointing you as the primary care doc. Obstetrician, OBGYN, gynecology docs are getting a lot of this because gynecologists get labeled as and used as the primary care doc for women. So one of the things we're doing is setting up our programs where we can provide that kind of prevention for those specialists who really didn't train in this area, and they're already way busy in their own specialty, and they just want to get the proper prevention for their patients. If you want to talk further, Michelle can get you hooked up with me. It's 859-721-1414. That's 859-721-1414. Oh, look, Gilbert was listening and popped that right up there. Keep that up there for a little bit, Gilbert, if you would. Thank you. And I'll go and answer and deal with some other questions. Big gaps galore on near everything. I think and I hope you're probably referring to prevention in the practice of medicine in the United States. And that's the truth. The bottom line is you get 300 people coming out of a large medical school. Out of that 300 people, you may, a few years ago, you were lucky to get 10 that went into primary care. And I'm just talking about family medicine or internal medicine. Your typical class of 300 did not get anybody going into prevention. I taught prevention at Hopkins. I ran the program there, training doctors in prevention, and there's just not enough of that out there. So the standard is to wait till somebody has a problem and then deal with it. That's not what they do with cars anymore. Maybe we could learn to do preventive maintenance on people like we learned to do with cars 10 years ago. Robert Simpson, good morning, Robert. How are you today? And I appreciate your interest. Vagabond Sojourner, my plaque 2, LPPLA2, went from 175 to recently 119 in the green. I would have never known about the inflammation marker LPPLA2 if not for you and your channel. Eternally grateful. Vagabond Sojourner, I've seen many of your comments. I know you've attended quite a bit. I really appreciate that comment. It may sound silly, but I do get tingles. I got tingles right now reading that. And I get tingles when I get patients like old Alabama Gardener. He has his own farm to table channel on gardening and the diet lifestyle. He put a comment up a while back that said, "Hey doc, I did your test and I don't have prediabetes. I've got full-blown diabetes. And I didn't know it. My docs didn't know it." And I'm not criticizing my docs, but you probably saved my life. And I would agree. I'd be happy to take credit for saving his life, but he saved his life. And that just happens a lot on this channel. People begin to learn this information. They go in, they fill in some of the gaps that most docs have in diabetes management, prediabetes management. And that just starts filtering out to adding a couple of decades of healthy life, non-disabled life. And that's what this channel is all about. So thank you again, Vagabond. John Tocho, blood pressure has been my one lingering problem. Seem to be able to go low carb, but BP is my final frontier. You're not alone, John. You're not alone. Watching. Thank you, John. And those of you who are watching, if you don't mind giving us a little thumbs up. Gilbert, if you could put that little thing on the side to show them how to do a thumbs up and all that business, I would appreciate it. When you do that, this is not so much self-aggrandizement. This is trying to get that message out for those people that have this problem and they don't know it. Quite often what you'll find is, well, the doc said I had a touch of sugar, but it's not a problem and we'll wait until we get into a bigger problem before we deal with it. I see that all the time. And that's analogous to saying, you know what? There's a little bit of smoke coming up through the floorboard of my floor in my kitchen, but it's not a lot of smoke. And, I'll just sort of keep a fan on to blow the smoke out. And when it becomes a real problem, I'll deal with it. That's what this is like. It's like if your doctor says you've got, quote, a little bit of sugar, your house is on fire. Deal with it. Don't wait. Vagabond Sojourner, good book, Breath by James Nestor. Yes, I've read that book. I think I did a book review on it. And Let Every Breath, Secrets of the Russian Breath Masters by Vladimir Vasiliev. I've not read that. Very interesting, and thank you. And those books do help you. Sometimes the science is not the absolute greatest in some of the breath-related books, but the message is there, and you get through a couple hours of reading that book, and you begin to understand just how important this issue is. Thank you again, Vagabond. Sheila Smith, sorry I'm late. Great topic. I'll have to go back to the beginning. I've instructed my clients to use specific breathing exercises to stop a fib. It's always worked. That is interesting, Sheila. I did not know that. Not totally surprised, but didn't know it. Lisa Sabaneth, God bless you always, Doctor. Thank you so much, Lisa, for sharing information. Your knowledge, God is with you. I appreciate that. And I personally have maybe a similar faith. I have spent a lot of my time teaching adult Bible school classes in our Methodist church, and getting into the details, especially Old Testament stuff, is just a lot of fun. Sheila Smith, thanks, Vagabond. We'll get that book. I love how the doctor tells who the researchers are. We're getting a lot of comments right now, and when we do, sometimes we skip over. I'm going to try not to skip, but if we do, we do. Sorry. Proper breathing controls the amygdala. And if you don't know what that is, not going to go there right now, but it's very important. I'll tell you that. We actually look at a specific CT study imaging the amygdala when we're evaluating people for dementia. The amygdala puts together things like emotions and blood pressure, and that's, I think, part of where Vagabond Sojourner is going. The amygdala also is critical for our immediate and short-term memory and memory-related items. It's also critical for connecting. It's where we connect all of our different wiring within our brain. So it controls the amygdala, settles your emotions down. Breath is the only body system that we have direct control for. Thank you, Vagabond. Hit the like. Oh, John, thank you so much for reminding people. Please hit the like button. What I was saying a minute ago is it helps get that message out, because if the AI, the artificial intelligence, looks at your responses, if you stay on for a while watching what we're doing, that's a big, big deal. If you actually click on it, it's a big deal. The biggest deal that the AI responds to is if you put this on your social media and somebody else sees it from social media, like Facebook, and they click back in from social media, that really tends to drive the AI saying, look, people are interested in this topic. Let's put that up and suggest it to others. Thank you again, John. McGregor, Sheila Smith, you have information on links for these breathing techniques. I'm a nutritional therapist. You can also find these from reputable channels on YouTube also. Sheila, if you would, just put a comment. These comments won't show when the posting of this video goes up, but if you'll go back and take a quick look and maybe add a couple of comments with those links for McGregor and others, I would appreciate it. Martha Reich, James's Aunt Martha. Aunt Martha, James is not here today, and he's attending less because he's eyeball deep in some other work. Janice says she's tired of hearing me say that James is eyeball deep, but he's a very busy man these days, trying to get us all set up for the Medicare Advantage program down in Atlanta, Alabama. Sorry for the topic change. Can glucose level ranges be used to help encourage weight loss? Example, never higher than X amount. Aunt Martha, that is a fantastic question. And the answer is an unqualified yes. There are a couple of things. I am what I am. I'm out here answering questions, and I'm getting ready to go down a bunny hole. But a lot of people are most attracted to our bunny holes because they are in this space. Let me start by saying yes, unequivocally yes. Now let me take what sounds like a major hard right and get into a general issue. Two of the things that happen when we get middle-aged is we get that middle-aged spread, We start getting a little bit fat. And our blood pressure starts going up. Well, why is that? Because we're starting to get insulin resistant. Now, with weight loss and insulin resistance, people think that we start getting fat when we're middle-aged because we're eating more. If you read the books by Gary Taubes, he's got 3 or 4 of them in this area in an article, The Big Fat, not the Big Fat Surprise, Why We Get Fat and What to Do About It. And he makes a great point. Dr. Bernstein, the father of diabetes care, is a big fan of this, and he says the same thing. I say the same thing. When we're middle-aged, we're not getting fat because we're eating more. We're eating more because we're getting fat. That sounds like a play on words and kind of goofy, but here's where that actually happens. And you'll see why your question raised that issue for me. So as we get insulin resistant, we start aging or we get too much body fat, we start getting those cytokines, our insulin receptors start not working. So our blood pressure starts creeping up. In our 20s and 30s, and we're thin, our blood pressure, I said blood pressure, I meant to say blood glucose. Sorry about that. In our 20s and 30s, our blood sugar tends to be around the 80s. As we get older, we start getting insulin resistant. One of the first things that we find is that our blood sugar, basal insulin and fasting sugar tends to rise. In fact, if I see somebody, it's considered to be a normal blood sugar, fasting blood sugar, 99 or below. In reality, 90 or below is the best. Why does it start climbing? Because those insulin receptors aren't working. You've got thermostats in your brain that just get more and more used to you having high blood sugar. Now, wait a minute. What's that got to do with fat and weight gain? Well, insulin has several different mechanisms, not just letting blood sugar from the blood into the cell where it's safe. It also has something to do with memory, which has a whole different set of bunny holes regarding dementia. But here's what it has to do with weight. Insulin stops fat burning. Well, if your blood insulin is routinely way too high, then it's going to be harder and harder and harder for you to do fat burning. Well, when is your blood insulin too high? When your blood sugar is too high. When's your blood sugar too high? When you're insulin resistant. So if you clean that stuff out and you start decreasing those carbs, you start keeping your blood sugar at lower levels, 90 or below, you don't have a high level of insulin all the time. And so then your body is not fighting and struggling to burn fat anymore. It develops much more of a fat burning metabolism. You go to other YouTube channels, other channels and sources of information on the web. They'll all talk about, a lot of them will talk about going from a carb burning metabolism to a fat burning metabolism. A key portion of that is getting that insulin down, that routine daily insulin level. And once you start getting that insulin level down, then you can start burning fat. So, Aunt Martha, that was a great topic. Some of the best topics are changes from the topic of the day. So thank you again. Thanks for this info. I plan to rewatch when I get home to absorb more. Thank you very much for your interest. Gianluigi, hi Doc, from Milan, Italy. I'm jealous. My wife visited Milan. My son visited Milan. They said that's their favorite place in Italy. And I still haven't been there. I've seen gurus on the internet saying keto is dangerous, long-term cause metabolic inflexibility induced by no longer eating carbs. Please, can you comment? Thanks. Yes, I can. The evidence is not there. That is just not true. There's plenty of, I was worried about keto a long time ago as well. Back in the Scarsdale diet days, and the Atkins diet days, and there just had not been enough research in that area. There's been enough research now. Long-term keto is not a problem. Now, then one of the problems that you get into is that a lot of people continue to assume that saturated fat is bad. They also continue to assume that the only way to do keto is just pile on the bacon and the animal fats all day, every day. Number one, if you think saturated fats are bad, take a look at my videos. Nina Teicholz wrote a great book, The Big Fat Surprise. Saturated fats have gotten a bad rap, starting with Ancel Keys. But that whole thing about saturated fats is not as well, being bad is not as well documented as you might think. And these days, now there's plenty of research out there that saturated fats are not bad. I've got a video on the most recent meta-analysis in this space. Meta-analysis means looking at all of the different studies that have been done on saturated fats. The JACC, I think you're a doc, you may recognize the term JACC, Journal of the American Cardiology, College of Cardiology. They've got a great publication on, it's a meta-analysis of saturated fat in the diet. It doesn't appear to be really good for you, but it doesn't appear to be really bad either, like everybody has said. So that's item number one about this concern about keto diet. Item number two, and it's the item that I've always said, when people say you got to go carnivore or full-blown animal fat to go keto, that's totally crazy. I've done it myself just for demonstration purposes. I'm going complete keto on a vegan diet. I don't routinely eat vegan diet for the reasons I just mentioned a minute ago. I've actually added more saturated fats than I had in the past. But you don't have to go full saturated fat to go keto. And saturated fat's not that big of a deal anyway, in my opinion. And again, I know I'll get some haters for some of those comments. Sheila Smith, it's unconscionable to me that doctors don't utilize the glucose tolerance testing. Me too, Sheila. In fact, like I said before, if there was one thing I could change about our world, it would be that doctors each year know to get their patient to get that, not only just OGTT, but measure those insulin values when they get the glucose. And they don't do it. There's statistics on that. It's really clear. A good system like, I'm blanking on it. It's that large HMO system that started out in Kaiser. A good system's like Kaiser, and Kaiser's a good system from a prevention perspective. A lot of people love to hate on them, but they're one of the better systems out there in the U.S., especially among larger systems. Here were the kind of numbers that you saw in a good system like that. It was like, only 60%, 60 or 70% got any kind of screening for blood glucose problems over a 3-year period. And this is 40, 50, 60, and 70-year-olds. We should be getting that every year. Of those people that got it, over half of them wasn't even A1C, which clearly wasn't OGTT, clearly wasn't insulin survey. It wasn't even an A1C. It was just a fasting glucose. And it's like, dang, the practices out there really do tend to be in the dark ages. And it's just something that, it's like blood pressure management was in the dark ages back in the 50s and 60s. It's got to change. It's going to change. But meanwhile, don't let it happen to you. Just go ahead and do what you need to do. Make sure that you get the right testing. Love you, Dr. Brewer. You tell the secrets people need to know. Thank you very much, Sheila. I appreciate that. Okay, after work, we'll send link, Dr. Brewer. Thank you. Appreciate that. Brutus, 198-55711. Hello, Dr. Brewer. Hello, Brutus. Bart, hit the like button, thumbs up. Indeed. Thank you so much, Bart. Susan Blanda. We've got a few more questions. Usually I'd have to jump off by now, but I don't have a competing thing today. I'll go ahead and see if I can manage a few more. Respirate is an awesome device. This is from Susan Blanda. It gives feedback to the individuals in a unique way via biofeedback. Yep. So, well, let me finish the comment and then I'll talk about that feedback for a minute. My husband had high blood pressure and was on 3 BP meds, I think is what you meant. Within a few weeks, using Respirate, his BP was 110/68. So yeah, what it does, it feels kind of awkward when you start it. It's got this little belt that goes around your abdomen, teaches you to breathe through your abdomen, not your chest, which most of us do. And then you plug in the feedback, and there's a voice. The belt measures how well you're expanding. It measures the inspiratory and expiratory phases, and it coaches you. It says, okay, it gives you music to inhale, exhale, and it doesn't do it like I did. It gives you different choices on music. And so it actually teaches you, it reads how you're breathing. It can read and say, you know what, you're not inhaling. Here, let's stop. You inhale now, exhale now. So it's a very interesting way that it does that. Thank you so much, Susan, for mentioning it. Sheila, Susan, what was hubby's blood pressure before? Highest numbers, thanks. And you feel a great sense of well-being using Respirate on a regular basis. It's better than doing meditation for me. It is for me. Dr. Siegel from Insulin put 800. Oh, this has been Benjamin. Dr. Siegel from Israel put 800 people on CGMs. 1 week of eating the same diet at the same time, the numbers were all over the place. Compliance was pretty good at 85%. That's interesting, Ben. Thank you for sharing it. Good morning, Dr. And I would say this, Ben. Now that the Freestyle Libre is out, it's cheap, easy CGM, continuous glucose monitoring. So the Freestyle Libre is a device. I've got several videos on it. You pop it on the back of your arm, and it measures your blood glucose 24/7, 24 hours a day, 7 days a week for 2 weeks. It's like $15 to $70 for each 2-week thing. Most insurance companies won't pay for it. Why? Because they're being stupid. I apologize. And the FDA requires a prescription. Why? Because they're being stupid. I'm sorry. Maybe I shouldn't be so. It should be over the counter. And insurance companies should pay for this. This is like, they'll pay for blood pressure measurement, but they won't pay for CGM. It's like, that's dumb. I think that'll change. But again, Ben, thank you for bringing up the points about CGM, continuous glucose monitoring, and giving me a chance to rant. Jonathan Hall, good morning, Dr. B. Can you please comment on the relationship between insulin level and prostate enlargement? Very briefly, thanks, and it's a great point. Most of us, at least most of us that have a prostate, tend to start getting some prostate enlargement as we age. And we have not connected those dots in the past, but there's a connection between insulin resistance and that. Really? Yeah. Look up IGF-1. Insulin-like growth factor 1. And there are significant relationships between that and insulin, as the name implies. That growth factor is very much associated with enlargement of the prostate. So is there good studies right now associating going low carb and improving your prostate? I remember looking at that briefly, and I didn't find a lot of stuff on it, but I do think I found something. Anyhow, I'm not going to be the expert on that today. I don't have the information, but it's a great point. It's a very good point. And again, I remember mentioning that 3 years ago, and I had a friend of mine who had prostate problems call me out and say, no, you're missing the bigger parts. I didn't mention some of the bigger parts of prostate enlargement and prostate cancer. That wasn't the point, but anyhow, it's a great issue, a great point. Jonathan, thank you so much. All it does is, again, underline how prevalent and how far-reaching some of the insulin-related problems are that people just don't get. Mezzanine, can you give examples of effective HIIT for the 50-plus crowd, coming from an endurance athlete background for decades? It's a really good point. I've got a thing called, I'm going to try to show you this. It might be, pardon me if this doesn't work, but I've got here in my office, you see that? That's a Nordic track. That's a great way to do high intensity interval training with no pounding on your joints at all. Janice doesn't do that because there is a little bit of balance challenge associated with it. And here's another way, an indoor cycle. Both no pounding at all. We've got a lot of people who are in the 60, 70 plus, more of a mall walker crowd kind of group. They will speed up their walking. That's one thing they can do. They will carry hand weights sometimes. They'll go up little hills when they walk. If you can, and then there's also high intensity intervals associated with lots of lifting on low weight, high repetition, lots of speed repetition on low weight dumbbells, starting with 5 pounds, 10 pounds, even 2 or 3 pounds. Squats, deadlifts, mild baby lunges, stuff like that. We've got people that have that are paralyzed. Their lower extremities are paralyzed and they're older, and they've got some things. It's a hand ergometer where they're pushing with their arms. So Janice is the expert in this area. She's got a doctorate in physical therapy and a couple of postdoctorates in health education. She's actually developed her own channel now. I'd go over to her channel and start asking her some of those questions. Somebody, who is this? Jonathan Hull gave us a super chat. Gilbert, if you could show folks how to do that, I would appreciate it. Thank you for everything you do. Thank you, Jonathan. And again, the vast majority of our income comes from me seeing patients, but these super chats make a big deal. We do a lot of in order to manage our costs to help get these messages out there, we do a lot of offshoring. Gilbert, for example, is in the Philippines. $4.99 goes a long way in Gilbert's, the economy that Gilbert and Sam and Aspen live in. So every super chat helps a lot. Thank you so much. Mezzanine, I have a Nordic track. You know, it's old guys. And pardon me if you're not an old guy, but I've run, I don't know, a dozen marathons and a ultra marathon, and I've done 80% of my training on that Nordic track. It's a great way to train. Sheila, I'd like to send you a recent study of specific bacterial strains on type 2 diabetes. I'd be very interested in hearing and seeing it. You can send it to our website. I think it's info@prevmedheartrisk.com. And Gilbert, if you could find that somewhere and show that, info@prevmedheartrisk. Mezzanine also has an indoor bike. So again, lots of ways to get IT. I bought a water rower. Oh, those are great. If you can use them and you have one, those are really, really good. No pounding at all. And lots of good, what we want to work, if you can move your legs, is you want to work those legs because those are the big muscles. And you talk about resistance training and muscle training, especially for men, they think about arms. Arms, they're okay, but they're cosmetic really more than anything else. What we want is big portions of muscle mass to push. One of the reasons for that is as our insulin receptors get stale and resistant, exercise bypasses that insulin receptor. So even if you have insulin resistance, it doesn't matter if you're getting routine exercise. And here's the other thing. They've done studies on this, and you get that insulin-like response from exercise. It goes for hours. For example, large muscle mass and intense work has this insulin-like response for up to 48 hours. Now, if you think about that, does it help you understand the fact that the science is full of literature showing we need to do at least 3 exercise components, sessions each week? Well, you do 3 each week and you're covering most of the week in terms of exactly what we're talking about, bypassing that sticking resistant insulin receptor. Mezzanine, great info. Thanks. Haywood Hall, my friend down in Guanajuato, Mexico. Haywood and I are starting to do some work together. His team's starting to support our channel, doing a lot of the work. In fact, Viney in Haywood's shop actually did the deck for the day. Viney and Chucho or Jesus and are doing a lot of these decks. Viney is a PhD molecular epidemiologist, and Jesus is a recently trained preventive medicine doc. Haywood is a double residency trained internist and pediatrician. He was one of the medical directors that worked for me when I was the CMO at MD Live. So thank you so much, Haywood. Good to hear from you guys. Bart Robinson, I'm on the waiting list for a rowing machine. Excellent piece of equipment indeed. Absolutely. Sheila, thanks, we'll send. Okay. John Tocho, rowing is aerobic and resistance all in one. Cycling is as well. And one thing that people don't often realize, something like rowing, you think of arms and shoulders. Yeah, it has some, but it's really legs and hips. It's those big, and back, obviously, those big erector spinae, those big muscle groups. And all of those, you get, you crank up the resistance, you're getting big muscles. You crank up the frequency or the pace, and you're getting high intensity interval as well. So thank you so much. Good comments. Yes, indeed, John. So I thought that we still have a couple more, and I'm going to finish those out, and I'm going to have to go soon. So Sheila, owning horses and distance riding, racing with all the hard physical labor. Yes. Loving to care for them has kept me and my insulin receptors in line. I wish I had my old Nordic trike though. I realize I'm dating myself with that old Nordic trike, but I love it. I've had 4 of them actually in my life. Ken Patu, rowing means push, don't pull. You're deeper into rowing than I am, Ken. Thank you. Insulin resistance is futile. Not sure what you meant by that. John, thank you, Dr. Brewer. Thank you, John, and thank you, guys. I really appreciate your interest today. We'll see you next week, and we plan on next week being Wednesday at 11 again. Thank you. Bye-bye.